المستشفى وعمل مجهود رائع، ويعني فعلا المستشفى بتقدم خدمات كبيره جدا لمحافظه بورسعيد. بنشكره. انا بس في كلمه قبل ما نبتدي البروفيسور جالسي.
First of all, let me say that I'm very glad to be here, and being, I feel like an Egyptian, probably more than Egyptian, because Adel El Tribi is not here, Amr El Adid is not here, but I'm here. So, having said that, I would like to say that during all these last 20 years that I've been visiting Egypt and Cairo and around, I realized basically that cardiac disease and coronary disease is very well represented by expert operator for two reasons. First, because you have a lot of disease, and this is the issue that you have to cope with interventional cardiology, which during these years have been progressed a lot. Secondly, because you have the skill, you have the capability, probably you are in the Mediterranean area, you are more smart than in the Northern Europe. And I would say that the skill that I found here are really more, I'm really impressed. I would like to thank Ahmed El Sobki, Yasser Sadek, and last but not least, of course, my friend Tarek Rashid, which is really actually I was a mentor for him many years ago, but I really feel that now he's one of the best operator in CTO and complex lesion. I was impressed. I was calling him a rising star, but now I confirm also with Yasser Sadek the same, that are both of them really very expert operator, and I'm really glad to be here with them, working with them many times in complex cases, and I'm really glad and honored to be here, part of this group and of this academy. And I'm really glad and really encourage all of you to bring to all your patients more and more interventional cardiology, because now we realize that we can do a lot with new stents, new devices, new techniques, and basically with new skills. It is really a great advance in interventional cardiology. This is along with the TAVI and other structural disease, which will be eventually widespread in the next future, and probably also in all this area. And probably now is not so much widespread because of the cost and because of this unfortunate pandemic that will slow down the progress a lot. But I'm sure that in the next future, this will be the next step for all our area. And thank you again for kind invitation.
Thank you, Professor Galassi. It's our pleasure, of course, to have you here in this workshop. And yeah, of course, it's a great scientific event by your attendance. So we will start now our scientific activity. Professor Galassi, for some tips and tricks for reducing the contrast in the cath lab.
Well, first of all, I would like to congratulate with Professor Nabil Farak for this fantastic and complete presentation on all the topics that he touched in this presentation. The only thing I would like to, I like very much this to cure heavy foot syndrome, which of course all of us have sometimes. So the only trick maybe probably to cure this heavy foot syndrome is expertise and knowing where to go with by the wire sometimes, or using the IBUS. I always remember that I am always impressed by IBUS operator, Japanese IBUS operator, because they do, sometimes procedures with 50 cc of contrast, and they do, for example, some of our friends, Satoru is one of the guy that is using very little contrast, and it does the whole procedures by IBUS. But of course, their experience is so much high because of their frequent use in IBOS, and we don't have their experience. But we, by expertise, we have the tricks to know by wires what to do. And sometimes when I work with some people around that are not so expert, they tells me always, let's see, we inject. Say, no, there is no reason to inject. And so this is something very important. Only one additional important issue is, I noticed that in most of the cath labs, sometimes radiation protection by the shield is not used at all. And this is not good for the operator. Secondly, the turret cover sometimes is not there, and is another problem. And also, the machine is not checked frequently by the X-ray operator. So sometimes this machine may produce more radiation than expected. Sometimes all machine may be needed more assistance. These are the three topics that I would really to encourage to push more in the settings, in the settings of your area.
Do you prefer putting a wire through the retrograde approach in a very complex case as a guide wire to have a map for crossing antigrade in very difficult cases? If you are not able to cross with a microcatheter, only wire in the retrograde by kissing wire, do you prefer this to reduce the amount of contrast?
Yes, this is a fantastic tips and tricks that we use. For example, the tip-in antigrade microcatheter, for example.
Yes. Injection from antigrade better than injection from microcatheter, better than the guide.
For example, the injection from the microcatheter, which reduce a lot of contrast. And well, as you know, this comes from experience and expertise. And I think that working with a more senior operator will tell you and will improve your skill and will adjust your aim and of understanding that without injection, you will appreciate more what you are doing, more than injection.
Are you still using 15 frame in your cath lab, or you are working on a 7.5?
We use 7.5, but I must admit that I am probably the one who is the worst sometimes to ask for 15, because I prefer at the beginning to have a better idea, and then to use 7.5 during the procedure. Because if I have an idea and a clear idea of the procedure, then I might increase the X-ray, but probably I might shorten the procedure because I have better idea what I'm doing. Sometimes with 7.5 you keep on going without understanding, and then you realize that you are doing a lot of contrast, a lot of radiation.
دي نقطة مهمة بس عشان نبقى مع بعض فيها، ان الراديشن اكسبوجر لازم نبقى واخدين بالنا من الهاي دوز. Do you have a limit for stopping the procedure? You will never continue above this radiation exposure?
Well, the one that has been stressed in the presentation by Professor Nabil Farag is basically what we usually we need to do. Generally speaking, yes, more or less 2 or 3 hours is more than enough for radiation. And generally we don't exceed 10 gray at all. 10 gray. Because 10 gray is really maximum dose that we should never exceed. Okay.
حد هنا بياخد باله من الراديشن اكسبوجر، ولا كلنا بنشتغل وبعدين نخليها بعد كده في الاخر على البركه؟ طيب دي نقطه مهمه جدا، that we have to recognize the radiation dose, and as Professor Galassi said, we have to start first by the 15 frame to see a better images, and then reduce your frame rate to 7.5, especially if you have a very long procedure. Don't work on the high frame rate. But this is your advice.
Yes, but also another important issue, I think, that we have to remember that sometimes in cath labs, nobody looks at the radiation dose. I realize this. That most
in Egypt, yes.
Yes. No, this is everywhere, not only in Egypt, everywhere around the world. Yeah. Don't look at the radiation. We have to be more careful on the radiation dose. The new machine are better than the older one, but the older one are giving a lot of radiation. So we have to look and understanding at the end of the procedure to understand how much radiation you give to the patient and to yourself. So then you will more prone to work in a better environment.
Thank you, Dr. Nabil. Sorry, Tariq, for just one comment. Thank you, Galassi, for this great comment, and Dr. Nabil Farag, thank you for this great presentation. I think for the team, you need to learn them when you come in, when you enter the cath lab. You need to go for the technician, show me the frame rate. This is very important. And you because if they accustomed to do this, they will learn to ask you, you want to reduce the frame rate? This is very important for the team. And also during the procedure, you can ask the technician to go to look for how much the radiation. This is a very important issue in reducing the radiation dose. Thank you.
ممكن أقول حاجة يا طارق؟
اتفضل يا دكتور عادل.
Well, actually, my advice also to use anatomic landmarks for your procedure, so that you can, by these anatomic landmarks, you can minimize injections and radiation. This is one thing, because if you have a stent, for example, you have an anatomic landmark, you don't need to inject all the time. This is one thing. The other thing is if you have calcification, for example, then the calcium would be your marker rather than injections. Second thing is that most new machines now can get you with the fluoroscopic injection. They can store it and you can see it rather than cine, because cine expose more and more radiation, and fluoroscopic injections are less radiation, as Dr. Nabil showed us. So these are my two additional advices.
Dr. Galassi, for contrast induced nephropathy prevention, do you think renal guard is getting much benefit for CTO's BCI, or what your experience for that?
If I have to say the truth, to find a renal guard in the cath lab sometimes is very rare, and probably it's better to be trained to use less contrast than to find the renal guard and use the renal guard.
Okay, thank you, Professor Nabil, for this elegant and detailed presentation about contrast and radiation management. And of course, we are short of time. We have to go for the next presentation by Dr. Freddy. So next presentation will be selection criteria for CTO PCI.
I would like to go quite fast, because otherwise live cases will be in the night. So, selection criteria for CTO revascularization are the important issue that has been already underlined by previous presentation. And what I sometimes I see is that usually the operator, this doesn't go. The operator, there is a reluctance to refer patient for CTO PCI, both from the doctors rather than probably from the patient itself. And this is due to some issues: unclear clinical benefit, and this is the lack of randomized studies, well collateralized vessel, especially among the operators which are not really involved in the CTO, cumbersome complex procedures, high radiation and contrast exposure, as Professor Nabil Farag showed us, the cost of the material of the procedure, and higher complication rates. And indeed, going to the first problem of the collaterals, we must remember that collaterals, even if they are present in a CTO, they are reducing the ischemia only in the 5% of the cases. And in the other 50%, in the 95%, 50% is the collateral flow is reduced significantly, and in the other 50% is really critically reduced. Indeed, if we look at this study that basically showed in patients with collateralized vessel how the information is getting from imaging, you will realize that even in a very collateralized vessel, all patients did have a lot of ischemia in the segment. So basically, the presence of collateral does not protect the patient. And if we look at the long-term survival benefit of this patient, we realize that basically we have that these patients who are kept chronically occluded with collateralized, even with collateralized vessel, do have a worse prognosis as compared to those patients who are revascularized. And this is also another experience from China, where basically the patients were comparing propensity score analysis. And again, the two groups, the one who were kept on optimized medical therapy, there were all vessels with collateralized vessel, and in the patients with revascularization, the PCI group, then at the end, in the follow-up, it was clear that those patients that were revascularized had a very better survival than those who were not revascularized. So basically, to have a collateralized vessel doesn't mean anything. Actually, so in other words, should we say that we should go and take from that and going into revascularize all vessels with CTO? No, this is not true as well. And we published this paper in 2015, and I'll be glad that I will probably run a consensus document in the next future in the European Heart Journal, because this document with this slide, which is probably simple, is basically showing you that when you have a presence of symptoms and you have normal wall motion on the left system, you have the need for to go into the revascularization indication. If you have symptoms or you don't have symptoms, but then you have either akinesia in the center or normal wall motion hypokinesia, then you should go for a viability study or an ischemia burden evaluation. And this can be done by MRI very recently, or by the old nuclear scan. And according to the result, if there is no viability, probably there is no reason to do revascularization. But if there is viability and it's a large viability section, then it will be important to do. On the other hand, if there is ischemia and it's a small ischemia, again, there's no reason to do revascularization. But if there is a large ischemia, or for example, a large ischemia of a major artery like LAD, then probably the indication is to perform revascularization. But of course, the increase of appropriateness of CTO revascularization passes through different three aspects, which is one is the advance in CTO PCI, because if you have a tool that you can work or you can use very efficiently, then of course you will use more and more. The second one is the importance of health outcomes, which can be the symptoms, mainly the symptoms of the patient. And then the third one is the more important, probably the prognosis, if the patient can live more. And going to that aspect, so we have to solve the problem of cumbersome complex procedures and high complication rates. And we started many years ago in 2006, three people, the CTO European Club, and then the goal was that to exchange experience among the most experienced operators, to test new technologies, to draw information from our own registry and also from registry from Japanese that they were teaching us how to do this CTO because they were the mentor for Europe, and then to issue state-of-the-art recommendation and teaching courses. And going with this experience, we understood that this is one of my first experience with the Japanese Masahiko Chai in my cat lab in Catania. It was more than 15 years ago. And basically, you see on the right a lot of materials, but now these materials are reduced dramatically because the improvement in technique and devices is much higher than in the past. But of course, still going back to the issue of our European group of people, we started to have the first result in 2011, and we found that basically our procedure among dedicated operators were okay, but of course still with some complication issues. But since then, we improved the number of centers, we improved the number of dedicated operators, we expand our as you can see here on this picture, and we have now all Egyptian friends among the non-European associate members, but still in the club, which is going into the middle between the United States and Japan. And these are the numbers that we are facing now. these are, of course, for 2019 period, up till 2019 period. 2020 is basically a disaster. We will update, but of course, CTO numbers are really much decreased. But going back to a standard due to the pandemic, but due to the standard, the number of procedure, now we have running a lot of associate members, so young fellows that are starting activity, and you can see the red bar on the right, that are basically those who are younger and they are still doing more and more probably than the dedicated old members. And also they are using, despite less number of retrograde approach than dedicated more seasoned operator, but still they have a lot of numbers. And then if we go to the percentage of success, we realize that nowadays the percentage of success overall is about 85%, which is reasonable and is growing during the years from 2008 to 2019 significantly. With more important, a reduction of major complication, which goes from 1 to 0.5. The only exception is for the coronary perforation, which are still above 2.5, and these are due to the fact that more and more we do retrograde procedures. But as we say, there are CTOs and CTOs. There are CTOs that are clearly on the left, very simple, and can be also attempted by no CTO operator theoretically, because practically this may be also becoming a disaster sometime. And those who are by default so complex that only should be attempted by a dedicated operator, because on the right, as you can see, very long CTO calcified long lesion, it is by default is a procedure that can be basically very complex. So the first one may be complex, the second one is definitely complex. And going to this idea and following the Japanese suggestion, when a GCTO score is more than 2, which is the score that is giving us the complexity, we should really leave this operation to those operators who are experienced or they are working with an experienced operator, while for the others, they might be, this is because, of course, success is improving more. And this is also the reason, because we realize that more and more the operator, even a dedicated operator, is doing the cases, more and more it will have percent of success increasing, and more importantly, decreasing of complication rate. And nowadays we want not only the success, but also the reducing of the complication rate. And also this is true not only among dedicated operators for an integrated approach, but also among people are doing only retrograde approach. If you are doing more retrograde approach, as you can see here, the red, you will see that procedural success will be more stable, even with increased complexity of the lesion, as compared to those who have less number of retrograde approach. So as you can see, it's like surgical operation. More you do these interventions, more you do your expertise, more you have less complication, more you have the benefit for the patients. But again, there are still, for the reluctance to refer patient for CTO PCR, there is an unclear clinical benefit. This was an old slide, but now the things are changing. And the importance of health outcomes are coming up a lot and significantly more than before. So the first is the concept of angina, but most of the time, sometimes there's not only angina, there's also dyspnea, exercise tolerance, limitation of activities. The issue that these patients are taking a lot of tablets, and also safe imaging and social functioning. We have to remember that sometimes, especially in this area, CTO, I realize, is happening in a young patient like 40 or 50, and these patients are limited in their physical activity. And of course, this is a very important issue to give back to this patient a real normal life. And if we go to the guidelines, and these are guidelines of 2018, which are still valid because we do not have new guidelines, we see that for symptoms, hemodynamically significant coronary stenosis in the presence of limiting angina or with insufficient response to optimized medical therapy is an indication of 1A. So if you see a patient like that with CTO, theoretically, you should go ahead. And very interesting, there is an update of 2019 guidelines for chronic coronary syndromes, and you can see that in the refractory angina patients with long-lasting symptoms for more than 3 months, there is also patients with bypass, stenting, including PCI for chronic total occlusion. So this issue is a very important issue for patients with refractory angina. And the quality of life of these patients is poor, with frequent hospitalization and high levels of resource utilization. And in this last recent publication that is coming out in the next few months, that I've had the honor to work with Thomas Luscher and in the management of an update of management of refractory angina, we clarify that in many studies, as you can see on the right, the incidence in these patients is CTO, 64% in the Cleveland Clinic study, 69 in the European Heart Survey, and also in the other European survey of the multi-vessel section. So CTO is present in most of the patients with refractory angina. When we started doing retrograde recalization in Europe in 2005, we published this paper, we realized that also, especially for those patients who are treated by retrograde approach, there was a benefit. And the patients were benefiting from reducing angina into not only at the 3 months, at 3rd months, but at 1 year, at 2 years, and at 3 years. So these patients were basically, which were successfully revascularized, having a good symptoms of angina relief, not only angina relief, but also reducing of New York Heart Association class of dyspnea, which is also very important for these patients. And also other studies in registry, they realized that symptoms relief was the major indication for CTO revascularization because of the reducing of angina frequency, physical limitation, quality of life. Although there were also other important indication for this revascularization. But of course, it was mainly also another study from the Japanese group showed the same improvement of quality of life for those who were successfully revascularized, but definitely what was important is to demonstrate that by a randomized study. And this is the only randomized studies from Europe that we run to confirm that when we have a CTO and we leave the patient to medical therapy, instead of revascularizing him, we will have significantly worse physical limitation, more frequent angina, more freedom of angina, and less quality of life. And if we succeed in revascularizing the patient, that is changing his life, his differences, with improvement of CCS class, as you can see on the left, optimized medical therapy, and going much less number of class on the right for those who are being revascularized. The final is the importance of prognosis, which is the most difficult part for CTO. We know that it's not only difficult for CTO revascularization, it's also difficult for, in general, for ischemic heart disease to demonstrate that if we do revascularization, we improve prognosis. Probably the most difficult the less difficult is the proximal eddy stenosis more than 50%, as is written in the guidelines 1A, and 2 or 3 vessel disease with impaired V function, because these are the 2 settings where basically improvement of prognosis may occur. And if it is true for LAD stenosis more than 50%, it will be also true for LAD CTO. Indeed, the importance of the presence of CTO is associated with high mortality. As we can see here, those patients in the red bar, during the years, they have less, more estimated hazard of dying than not to die when they have CTO. And this is also true, especially if they have multiple CTO, and they are proximal location CTO. So this is very important to remember. Also to remember that also CTO, as you can see here, may be present in all cause of mortality in those patients with ventricular tachyarrhythmias, which in these recent studies has been shown to be one of the case. And finally, in this our EU intervention point of view, point of focus, consensus, we focus on this study, the IMPACTOR, which is another randomized study, a small randomized study that we ran, where we basically proved that if we revascularize CTO of right coronary proximal lesion instead of not revascularizing in a randomized fashion, we have a better quality of life and better ischemia reduction. So this is another piece of evidence for this, as compared to the Explorer, which was not able to show any amelioration of the symptoms because probably the follow-up was only 4 months instead of ours that was 1 year. And finally, to go to the more evidence, which is, although not a randomized studies, these studies, which was run in the Italian Register of Chronic Total Occlusion, show that basically if we revascularize this patient as compared to medical therapy in a propensity score match analysis, we will have again amelioration not only of symptoms, but also of survival. So this is also not a randomized study, but is again a study where matched population were compared, and so it can be of some value. In general, all studies, you can see from 2016 to 2005, confirm that might be an improvement of ejection fraction in this patient. But as we know, to improve 4% of ejection fraction in a patient who is normal, with normal LV function probably is not important, but in a patient which have depressed LV function is totally changing the history. And in this meta-analysis of CTO PCI versus optimized medical therapy, those studies which were propensity match observational studies showed us that probably there is maybe also some lower CV death driven by observational data as compared to the randomized studies. But the randomized studies, as you know, they have the problem of selecting the patient which are the best patient to randomize, and not the same as the studies in the propensity match score analysis. As we did, for example, in this group of patients with low left ventricular ejection fraction that were basically studied, they were the follow-up and where basically we understood that the predictor of MACE was mainly the depression of left ventricular ejection fraction. And then when we revascularized this patient, we realized that we improved significantly, even up to more than the 4% that we were expecting in a general population, about almost 10% ejection fraction in this patient fully revascularized at a follow-up of almost 1.5 years. So this probably in this patients group will improve prognosis significantly rather than generally speaking in patients with normal LV function. So going back to the slide, I would say that probably as this table is still appropriate and is reasonable, so we should be able to recommend revascularization when there is ischemia, when the operators are good expertise and appropriate dedication, when to improve symptoms, not only of angina, but also of dyspnea, but also to guide reducing the risk of premature death. And this paper of the reduction of ventricular arrhythmias may be of some in this direction. Also, we need always to choose the best treatment between coronary bypass graft and PCI. And I would say, and I would add an important issue, which is mainly the idea to look at diabetes, because if you have insulin-dependent diabetes, which is very frequent, for example, in Egypt, I'm not so sure that we do the best if we treat the patient by PCI, even in the presence of a CTO. We must do the best, or we can do the best in the presence of insulin-dependent patient only in the case of post-CABG or last remaining vessel, situation where basically a resurgery may be of really of high risk. And this is what is written in this consensus document from the Euro CTO Club and more. Thank you very much for your kind attention.
Thank you, Professor Galassi. Just I have a question, a rapid question. In your opinion, why always in meta-analysis data comes in favor of CTO PCI, and in randomized trials there is no strong evidence for CTO PCI? If this is due to the study design, due to always crossover, or what is the reason for this?
There is different aspects. For example, in the study which is called Explore, is basically was due to the fact that, as you say, many patients crossed over, and then instead of keeping on the medical therapy, they were switched to PCI. It is also true that most of the patients, the doctor, don't like to have medical therapy in the presence of severe symptoms, so the patients start to decide to be revascularized, but mainly depends only on the fact that in randomized studies, you have a different population from the real settings of the patient where the benefit can be seen. And in this situation, you will see that you will find in the randomized study, you will have patients with the small CTO of small vessel, not relevant, little symptoms, patients probably not really, in which probably even a dedicated operator will never approach a CTO. And this settings is making confusion and regardless the indication of the true CTO intervention. This is the reason why the propensity score mesh analysis, in our idea, is probably more appropriate in looking what we are going to look for the future, especially for prognosis, because in prognosis, we will never assess prognosis, not even for CTO, even for coronary artery disease. The ischemia trial is a lesson for that. And also the courage trial is the same lesson for us. But if we look at the sub-analysis of those patients with severely complex in terms of severely ischemic patients and severe depressed function, there is the real benefit of the patient. And more and more that we work in these settings, we realize that we face patients which are really giving us the value of what we are doing, because we change the history of these patients, doing a CTO of a patient with low ejection fraction, which improves and which basically cannot do the procedure because it's a post-cabbage or does he have other limitations. So these are basically the settings where we should work. And as you said, probably these are not addressed in the randomized studies at all.
Okay, thank you. I have two only comments that in Egypt we have a CTO in a very young population. Do you have the same in your country, or always it's in a very old or?
In young patients, I come from yesterday procedure, which was, we did CTO of, LAD of CTO of a patient who was 45 years old. He was not diabetic, heavy smoker. I would recommend. In a patient which is highly diabetic with a lot of disease and diffusely disease, and I know that I will implant a lot of stents and is insulin independent, probably I would switch to surgery nowadays, because we realize that implanting many stents in insulin independent patients, especially in young patients, will not improve his future.
Okay.
In
the era of pandemic,
can I say something, Atari?
Like COVID, we have to lower the threshold for CTO PCI, or to follow the same rule for doing the intervention for chronic total occlusion, right? Large ischemia, symptomatic patients, or we have to wait more and we have a very low threshold for PCI?
This is a big question, because we thought that this pandemic would have been lasting 6 months. Then we thought it was lasting 1 year. Now we are thinking it will last in 2 years, probably it will last 3 years. We realize in Italy, for example, that we are reducing dramatically the acute case of CTO. And patients are not going to the cath lab anymore as before, and we have a dropping of 35–40% of acute CTO, acute MI patients. This will turn up to be like less industrialized area to be CTO in the future. So what we are facing now, we had, for example, a breakage of between September and November, which the virus seems to be a little bit less aggressive in Italy. And we faced back again a lot of patients who had the symptoms of acute MI during the pandemic, and were coming back as in the past with subocclusive disease or CTO. And it was funny because we got back as, for example, 10 years ago. So what we are facing, what we are going to face in the future, I would suspect more CTO than in the past.
Okay.
How could we treat this? I'm not so sure, because it will depend on the situation and the regional and local availability of cat labs and expertise, because this is a very big problem that probably we don't know how to solve.
Okay. Thank you for this great presentation. Any question from the audience?
أنا كنت عايز أسأل حاجة يا طارق.
So we will move to the next presentation by Dr. Muhammad Imam. The next presentation will be optimizing the procedure by optimizing the support and optimizing the adjunctive devices for getting better results.
ليزر لا خلاص.
Dr. Muhammad Imam is a pioneer interventionist in Egypt. He is on his track to be a CTO operator, and he is persistent in doing everything. He is caring about his patients. So we will listen to Dr. Muhammad Imam, and we will wait for him to be the new CTO operator in Egypt. Okay, Dr. Muhammad.
At first, I would like to thank everyone who is sharing in making the dream in Egypt a true reality. I would like to thank Dr. Tariq Rashid and Yasser Sadiq who gave me this opportunity to be with you today.
Thank you, Dr. Muhammad.
This is the agenda or the outlines of my presentation today. How to optimize the result of our CTO procedure. At first, the guide extension and the trapping balloons, specialty balloons that is manufactured for CTO procedure, IVUS, atherectomy, hemodynamic support. At first, the guideline extensions, the trap liner overview, integrated trapping balloon. The wire used is 0.014. It's a half pipe designed to facilitate device entry and delivery by directing and aligning devices through color transition. This is used in case of heavily calcified lesions and in lesions with high tortuosity, that the device is not passing by the ordinary ways. There is two devices, the Godzilla and the guide liner. There is 6 French, 7 French, and 8 French. Nearly the inner diameter and the outer diameter is nearly the same, with slight privilege for the Godzilla. This is a trapper exchange device. This is a single dedicated product engineered to allow treatment and facilitate device exchange without losing wire position. We usually in the CAS lab use an ordinary trapping balloon, but this device is used in order to use it multiple times. It has a distal distal mark band 1 millimeter length to confirm its position in the guide caster. There is a core wire tip to hub for durability during multiple uses. It is a non-compliant balloon. It is 2.4 millimeter. It's used between 6 and 8 French. It has a low profile. It is 2 French diameter. It has an orange manifold in order to easily identify it. Sometimes the ordinary balloon is not the best option. We can use a Sprinter Legend 1.25 semi-compliant in order to pass lesions difficult to pass. This is a plaque modification balloons, such as angiosculpt, Flextome, the cutting balloon, chocolate balloon, the Wolverine, and recently the Shockwave balloon. IVUS is a very useful tool in CTO procedure. There are two devices, the Boston Scientific and the Philips IVUS. The data in ordinary all-comers BCI is favoring IVUS usage because it decreases the intralumen loss. IVUS guided CTO BCI is favoring also IVUS. It's better in non-IVUS guided BCI. What's the uses of IVUS? At first, it resolves ambiguity if necessary. If the vessel is chronic total at the site of bifurcation of a large diagonal, the IVUS is used truly delineate the stump. Confirmation of distal true lumen after passage of the CTO. Proper vessel preparation, evaluation of vessel size. After opening a CTO, it's usually smaller in size. We need to use the true sizing in order to decrease the late lumen loss. This is the scheme for using IVUS. At first, intravascular imaging. If it is uncrossable lesion, it would delineate the cause of uncrossing the lesion. After passing, we use it to delineate the size of the vessel in order to use non-compliant one-to-one measuring. And if we are in need for mechanical atherectomy or laser atherectomy, then it optimizes the stenting procedure in order to delineate the size, in order to decrease the late lumen loss. It's used to post-stent evaluation in order to see if there is a residual lesion or a part of mal-adapted stent. Atherectomy. There is a laser atherectomy, excimer laser. It's only found in Magdi Yaoub here in Egypt. The rotational atherectomy is a rotablator. It's with different burr level. It's used between 6 to 8 French guiding. Hemodynamic support. The Imbella is the most easy one to use. It's percutaneous. There's Imbella for the left side and the right side. Summary, having the right tools will improve efficacy and outcome. Having the right tools and knowing how to use them aren't always the same thing. Practice in non-CTO shape cases at first and attend the continuing medical education.
Thank you, Dr. Muhammad, for this elegant presentation. Yes, any question?
Thank you, Dr. Muhammad, for your presentation. I'd like to ask one question. How could we test the support of guiding caster before starting CTO procedure, either it is supportive or not? In some cases, AL1 and XB4 is not supported.
I think you have to get this from the diagnostic procedure. First, you have to see what's happening with the diagnostic catheters and to check everything. and then you will choose your catheters. We have some selection, معلش محمد يعني just we have some selections for each vessel. So if you have LAD, usually you prefer the larger catheters. So use XB4 instead of XB 3.5. Sometimes we use Amplatz left 2 or 3 for the left circumflex. For the right coronary artery, usually we use Amplatz left 0.75, which is now available in Egypt, or Amplatz left 1. This is for a better support. So this is a very important issue, is to optimize your support before starting CTO PCI. This is a crucial point for success. If you didn't optimize your guiding support, most probably you will face a lot of problems due to the problems of the guiding support. After optimizing and choosing the right support, and this is usually comes after diagnostic catheter and by experience, you will see this is better for this anatomy, this is better for the high takeoff of the right coronary, this is better for the abnormal origin of the right coronary. You will get this by experience. And second thing, after optimizing your support, you have to put the plan for more optimization. If you have a very proximal right coronary occlusion and you have a side branch coming before this occlusion, so we can put a less supportive guiding catheter with an anchoring balloon. So you will increase the support. If this is not enough, you can use a guiding extension. Some devices can support you. The devices Dr. Muhammad showed us. You can put only wire, not an anchoring balloon. So we have a lot of tricks to support. Dr. Garas, you have special tricks for getting more support?
No, the one that you said basically are those.
Of course.
I found that anchoring balloon is still a good option, despite its old technique is still working very well, sometimes even better than extension device.
Guiding extension, yes.
Yeah.
And you can anchor within the body of the CTO also, exactly. not in side branch. If you don't have a good side branch and you are in the CTO, you can anchor with the balloon with this.
Yes. The only suggestion that I would like to say is that if you think that you have a very big side branch and you have not very good backup, probably the best would be to have a 7 French guiding so that you will work easier with this two, with the anchoring technique.
Okay. Also, we prefer the larger diameter. So 7 French will give you what's called more passive support. You have to differentiate between the active support and passive support. Active support is the diameter of the catheter. So XB4 is more supportive, will give you active support more than XB 3.5. 7 French catheter will give you more passive support. What is the passive support? It's only a relation between the device and the guiding catheter. When you increase the diameter of the guiding catheter, you will decrease the friction between the devices, and this will increase your support. So bigger diameters will give you more support, and this is preferable in CTO PCI. Of course, you have to, as Dr. Muhammad said, prepare everything. If you have a calcified lesion, prepare the atherectomy or plaque modification devices, rotablation, other devices, and low-profile balloons to cross. You have to think before doing the procedure. And you will need a more supportive microcatheter. So if you have a less guiding support, a better microcatheters for support like Turnpike, Spiral, like Corsair. This is a more supportive than pushable microcatheter like Fine Cross and Caravel. So you have to choose everything before starting the procedure. This is the aim of this lecture. So anybody have any question for Dr. Muhammad to go for the next presentation by Dr. Galassi also? How to choose the microcatheter.
Dr. Tariq, yes. I want to mention that the guiding wire and the microcatheter is a very important issue, but I didn't mention in this PowerPoint presentation.
Of course, we have a separate presentation for microcatheters and PCI wires. بس عشان نبقى واضحين مع بعض، احنا عملنا شويه تعديل بسيط. احنا هنخلي البي سي اي وايرز اخر حاجه علشان بعد كده هنروح نطبق الموضوع على السيميليتور على طول، عشان يبقى الكلام بتاعنا ما يبقاش كله يعني حاجات نظري، هيبقى فيه شويه عندنا حاجات براكتيكال على السيميليتور. meanwhile واحنا شغالين على السيميوليتور اي حد هيبقى عنده اي استفسار في القصه دي هنتكلم عليها، وهم هيبتدوا يشتغلوا هناك اللايف كيسز. فعلى ما احنا هنكون فهمنا ازاي التعامل مع الوايرات، احنا الحمد لله معانا برضو بنشكر يعني شركه اساهي، دكتور احمد وهبي، دكتور محمد طه من بي ام ايجيبت، ان هم متواجدين معانا هنا يعني هيورونا حاجات تكنيكال سبورت الحقيقه هتفرق معانا كتير عشان نفهم يعني ايه الواير ده وازاي نتعامل معاه. Okay, we will go to the next presentation. Yes. Dr. Galassi.
Which microcatheter in CTO vascularization? First of all, before saying which microcatheter in CTO vascularization, I would like to remember that when I wrote many years ago, now 10 years ago, this tip and tricks for CTO, we basically clarify at that time that to work with a wire alone without microcatheter would have been going into this issue. To have basically, this is not working. Oh, anyway, okay. To have basically this wobbling of the wire instead of having the wire definitely directing into the CTO body of the lesion. And more important, to give more penetration to the wire once the wire was facing the CTO plaque. And so basically giving the real value to the wire rather than to give a value to the wire which was incorrect for that wire. For example, I was using even sometimes a floppy wire, but with the microcatheter you have increased a lot the penetration power. So to those people who think that microcatheter are useless, I would say that probably this is very wrong. And nowadays, even if they have a little bit of additional cost, you should never approach the CTO without a microcatheter. Having said that, as a backup of the situation, then we go to what basically Tarek Rashid was saying, basically that we could choose between good guiding back and less guiding back, and depending on that, on the situation, for example, not very calcified lesion or osteal or very proximal lesion, and planning, for example, and the great section re-entry, choose two different kind of microcatheters. Those who are pushable, as Rashid Tarek was saying, and one which are rotable. And for the pushable one, we have the old fine cross and the more recent MCAT, which is a little bit bulky, but is working quite well. And for rotable microcatheter, we have probably one of the best, which is the Corsair, which we will see now is Corsair, Corsair Pro, Corsair Pro X, and 2-pi Spire, which is still, I think, is a good alternative. And these are basically the pushable ones, and these are the rotable ones. You can see that they are totally different. These are basically a braid which is not changing in diameter during the shaft. And while here you can see that there is a different size of shaft, and also hydrolytic polymer coating, which makes you the drilling easier, and as this one, and making basically also the structure of the microcatheter more cumbersome, and this at the end also more costly. And this is in fact a standard microcatheter. In the past, this is a different settings of a modern microcatheter for rotation. And in fact, for the Corsair, this is the first prototype of the Corsair. We have, you see, the differences of the diameter and the differences of the hydrophilic polymer coating. And then with time, we understood, and this was coming in the Corsair Pro, that there were some part of the microcatheter which were suffering this torqueability. And one was in the proximal area, one was in the more distal one. The more distal one was reduced this by reducing increasing the flexibility of the microcatheter and taking out this marker. And in the proximal area, trying to give more to a sort of proximal device, dedicated device for twisting without having a breakage of the microcatheter. And indeed, the Corsair Pro changed the story of the Corsair itself, because it was used much better. And as you can see here, in this Phantom, this is a Corsair Pro which goes straight away, and this is on the left, it's not working, unfortunately. If you can play this video, exactly, you will see that this will not go because there is this part of the device which is not getting into the artery. So this comes from the progress that we have been used. But also after this, we also understood that rotational and push was mainly the main reason for this, basically to make this device successful. And basically, with the new edition of the Corsair Pro X, we realized that basically this thing is not working anymore, okay. We realized that basically we have even more sophisticated microcatheter, which have a thinner distal tip, new Shinka shaft, which is basically a shaft which has very hydrophilic power, and more or less the same kind of 14 wires braiding which were used in the past, which more increasing deep of this widening braiding, small widening braiding inside. And this makes basically a lower profile, tipping portion, and the difference between the distal and the smoother taper part of the mid part makes this advancement of this Corsair basically very much effective as compared to the previous one. In addition, it can be also used, as you can see here, 2 Pro XS in 7 French, Pro XS plus IBUS in 8 French, so it gives you the facilities to work with more capability. Going back to other kind of microcatheters, so here we have the Teleflex microcatheters, and we have basically different, as you can see here, different types of, again, rotational device. But again, you can see that the structure of this rotational microcatheter is totally different. So this is the one why it is more expensive in price. And if we go here to the different types of turnpike of the Teleflex, you can see that there are, for example, different types, spiral for rotational, gold for very sort of calcified lesion, although this is probably not really the ideal one for this calcified lesion, and probably turnpike LP, which is the most effective one. And this is, for example, an explanation for how can be used a spiral into a lesion, which basically, as you can see, twisting the catheter, it will, even without a lot of backup, will allow the microcatheter to get inside. And this is very interesting because even without good backup, the microcatheter itself makes the screwing inside the artery effective. This tells you the differences in the profile. I think that we need a new one of this because it's not working. And you can see also that the different profile is mainly getting the benefit, although the shaft of the microcatheter is still quite large. This is because you need to make sure that you can do the twisting. The distal tip is smaller. And again, all campuses now are coming with the products. This is Boston with the Mamba. Then there is MDS with this microcatheter. Then we have Teleport, Obus Niche with this microcatheter. So all campuses now are developing microcatheters. Supercross, again, from Teleflex. It is a cheaper microcatheter, and it's probably the weaker one, but it also can be used for simple lesion. And also interesting is maybe adapted this type with the supercross angle tips, which can be used frequently in very angle lesion, which is basically substituting the old venture from Teleflex that now is coming back again on the product and is probably a good solution as well. Then we have the tornus that probably is used not so frequently, but is used quite well in calcified lesion. And this is basically a different system of rotational. We have like a burr, which can be manually rotated inside the lesion, and should be learn how to rotate. This is a case of CTO. Probably we should lower the light in the room. Lower the light in the room to make sure that we can see. And we should also have a new pointer because it's not working. And you can see in this CTO of LED that basically seems to be a very simple LED CTO. But basically when we go and we approach the lesion, we were obliged to work with the Confianza Pro and parallel wire technique because of the high grade of calcification. And also after a lot of strength, basically we were obliged to use the tornus. We need to lower the light. And the tornus was making is basically working like this. You have to trap the back part of the wire. And this is the video from Osama Kato, which basically with the back part of your hands, you keep the wire, avoiding to twisting the wire, and then with the two hands, you are trying to twist anti-clockwise the device several times in order to penetrate inside the occlusion and sometimes unlocking the Y connector. Doing like this, you basically have a penetration power which can be effective, and you can see that you need to adjust with both hands. You should work with both hands so that the back part of the right hand is keeping the wire and the other two hands are working on and then relieving the hands, the torsion will come back again. And it's very important because if you twist too much, and as you can see here, you break the tornus, and you will see, without the pointer, I cannot do it, but there is a black part that is coming there in the middle, and this comes is the middle part of that gives you the idea that the device is broken and you should not go any further. And doing like this, after balloon dilatation, we had basically a successful procedure. Then we have the microcatheters for retrograde CTO approach. And here, instead of pushing and twisting, here we have the problem of choosing the microcatheter based on the septal or epicardial crossing. Generally speaking, septal crossing are easier, and so you can rotate and you can use corsair, turnpike. For epicardial, probably it's better to use corsair and turnpike only with big epicardial vessel. Again, here you can see on the left 1.5, while on the right, if the epicardial is less than 1.5 millimeter, it is better to use a low profile microcatheter that you don't need to twist. Because if you twist in an epicardial, small epicardial vessel, a microcatheter, you might have a very big disaster. You can loop the whole microcatheter inside the artery. And so in this situation, fine cross, which can be pushable, turnpike LP, Caravel is probably the best, or micro 14 are the one which usually we use. And here are basically two types of the microcatheter: the septal crossing, turnpike and corsair, or for epicardial big artery, and the epicardial crossing for small epicardial crossing. We cannot reduce the light, because unfortunately now there are films, and if you want to see the films, if we don't have reducing light, we cannot see anything. Is it possible? And here basically, this is what basically you can see with a corsair. Basically you have exartery trackability, even in an epicardial vessel, but this is a big branch, it's 1.5, so you can go around like that. And you might think that sometimes in a branch like this, as you can see here distally, it is almost impossible to look that you can find that this corsair will go, and indeed is going through. So this is made the retrograde approach totally another world, another of a success. Imagine a collateral so small like this one, which can be basically used, where basically the wire gets, of course, without any strong pressure, gets into the collateral because of new wires, like for example, this is a cyan blue passage, and then microcatheter can follow, despite being very small, can follow the vessel. And then of course you have to trap, you have to remove the wire to make the result successful. Or cases like this where basically you have a very small collateral, very tortuous, like that in the distal part of the vessel, and then you use the dedicated wires like SUO3, which is a new wire for small epicardial branch, and you can see that the wires gets by itself into the vessel without pushing a microcatheter. The microcatheter will follow later. And in this situation of a small epicardial catheter, there should be like a synchronicity between the small wire, the SUO3 dedicated wire for epicardial and fine cross, but never twisting and never using a catheter which can be twisted inside, because otherwise you will have a big damage. And then at the end, you will see that the recanalization is obtained by antegrade after crossing and extending your wires. And this is the final slide that basically show you how much now we are using in the EuroCTO registry. We were using corsair in the past, and now 8% are growing the new microcatheter use, and this is changing the history of the CTO. And nowadays, basically, this tells you that basically most of the, this is in 90% of the lesion of CTO, we are using this, and we are using, in the majority, we use corsair, in the minority, other catheters. So in conclusion, the use of microcatheter is a must for CTO revascularization, and always think 2 times when you don't want to use a microcatheter, because you will pay then the cost of it. Indeed, the progressive desire for microcatheters are dedicated to improve efficiency and success rate of CTO intervention, both antegradely, both retrogradely. And a full spectrum of microcatheters nowadays in 2020 are available in the CTO toolbooks and should be used more and more in the open mind to know which one to use in which category of the settings of the CTO itself. Thank you very much for your kind attention.
Okay, thank you, Professor Galassi, for this detailed presentation about microcatheters. Just, I think all the attendees want to know if we are working in cath lab with a very limited resources, and we have to choose a microcatheter.
The cheapest one nowadays are here. I think
Fine cross is
fine cross,
yes,
and probably is the best also in terms of comparability with the others. And then going to the torqueability, probably I think that Turnpike LP is cheaper than Corsair Pro, or probably more or less the same. But in the settings of the torqueability, I would say that Corsair Pro X and Turnpike LP are probably the best, to my experience, to be.
Do you think we can depend on only one microcatheter, or at least 2, to have one pushable and one?
Well, yes, this is the case when you have retrograde approach. Definitely, sometimes you. No, generally speaking, yes. If you have a pushable one and a rotable one, the 2 kind of catheters, then you can have a wide spectrum of.
So enough to have a fine cross and Corsair. This is enough to
probably this is enough. If this is the best prices, probably this is enough. Yes.
Of course. And if you are going to add a 3rd one, which one to choose?
Caravel, probably because Caravel gives you the most advantages for the small branches in the retrograde approach, for those who are doing retrograde approach. Because as we know, Caravelle is, as we said, is a microcatheter that is not designed for torqueability. I will show you in my presentation of the collaterals, the value of the microcatheter and wires together.
Okay.
And so this will expand the concept, but
right.
I need to have the pointer for next presentation.
Okay, no problem. So just to know, we have two types of microcatheter. The pushable one, and this is usually used in epicardial collaterals or the lesion that doesn't need a great support. So this is like a fine cross. And the other microcatheters are the active movement microcatheter by rotation, like Corsair, Turnpike. Those are microcatheters that store energy by rotation, and this energy will take the microcatheter through the collateral or through the occlusion. At least we have to have one pushable and one rotatable microcatheter. This is for the beginning of CTO PCI, and you have to choose the microcatheter according to the situation again. This is a very important. If you are going to do an antegrade approach with the EGD lesion, you can use this pushable microcatheter for decreasing the cost of the procedure. If we are going to do a very tough lesion with a heavy calcification, so at this time the pushable microcatheter will not be suitable for this situation. We have to use the other one, which is the rotatable. I think Dr. Galassi showed us a very important video about how to rotate the microcatheter. But after finishing this session, we will go to the simulator and we will start showing you how to use the microcatheters and how to use the wires. So this is only for refreshing knowledge and for refreshing informations about the CTO, but you have to wait for the practical part of this workshop. Of course, Dr. Galassi, after finishing this session, will go to the cath lab and he will start the live case. While we are doing the simulations, or we are doing the workshop on the simulator, we will mix between the live case and the simulator because we are not able to move all of us to the simulator. So some of us will sit, we'll review the live case, and the others will go to the simulator, okay? Thank you, Professor Galassi, and we appreciate what you are doing with us today. A great presentations, live cases and everything. Any questions about the microcatheters?
Thank you, Dr. Galassi, for this presentation. I'd like to ask, in calcific lesion in retrograde approach, fine cross or carval, sometimes it is broken during the attempt to crossing calcified lesion. What is the best microcatheter if we are using epicardial collateral for this calcified lesion?
For epicardial lesion, I would say that probably and calcified lesion, probably Corsair Pro XS is the best, and together with Turnpike LP. Caravelle in calcified lesion, I would skip because of the possibility that you might break it and lose the distal tip of the microcatheter. So unfortunately, this is the combination of calcification, small vessel, retrograde approach gives you the most difficult scenario. And in this situation, probably the only device that can be able to solve the problem is the Corsair Pro XS, I would say, because this is the scenario that you are making is the most complex one: retrograde, small collateral, and calcification.
Okay, thank you. فاحنا يعني بنتكلم على الجايا سكند. الجايا سكند هو انترميديت ستيفنس واير، زي ما اتكلمنا هو له سبيشال مانيبيوليشن. ما ينفعش ان احنا نمسك الواير ونزقه او نعمل رابيد موفمنت. طبعا هو اول حاجه هنا
يعني طبعا اول حاجه خلي بالك ان المايكرو كاثيتر دي تبقى فلاشد كويس قبل ما تخش، وكل ما تخرج واير يستحسن ان انت تبتدي تعمل فلاشنج عشان ما يحصلش سكشن للاير وانت بتسحب. السحبه السريعه دي هتدخل اير جوه المايكرو كاثيتر، فبالتالي وانت بتسحب الواير ده انك اعمل فلاشنج للجزء الهب بتاع المايكرو كاثيتر ده. طب احنا هي دي المايكرو كاثيتر اللي باينه ولا؟ ما هو ده المفروض ان هو حاطط لك يعني تيبرد ليجن يعني. هنشوف دلوقتي. هو احنا كده شغالين ولا؟ اصل انا حاسس ان انا ابتديت اخبط في اهو هيبتدي. دي كورسير. طيب دي الكورسير العاديه، بس دي ال 135. ليه ال 135 التيب بتاعها بيبقى لايت بلو، الثانيه بتبقى ازرق غامق شويه، دي لبني. الحاجه الثانيه ان هي الهب بتاعها بيبقى الثاني شويه مطور في الكورسير برو، بحيث ان هو يقلقوا البند احسن، بيبقى شكله كده بيبقى مشرشر يعني، ما هوش سموث زي ده. ف ماشي. ادي التيب بتاع المايكرو كاثيتر اهي. احنا مش ادي المايكرو كاثيتر اهي خلاص، بس هو المشكله عندي هنا التيب فيه حاجه في ريزيستنس في التيب، ما اعرفش بقى ايه. بس اهو ماشي خلاص. الواير اهو خرج يا باشا، وخرج غالبا حاطط حاجه عليه. ايه بقى اللي عليه ده يا باشا؟ غالبا الحاجه دي كانت جوه المايكرو كاثيتر. لا هو غالبا خدت واكس من البتاعه دي، فده هيقلل شويه الحركه بتاعت ماشي. طيب هناخد التوركر بتاعنا، وعشان نبقى متفقين على حركه الواير. الواير اللي هو البوليمر جاكيت بنعمله كده زي ما انت شايف كده خلاص. دي حركه اللي انت شايفها دي حركه البوليمر واير. ما ينفعش معانا في الجايد دي، تنفع في السلايد، انما الجايه بقى احنا لازم نبقى عارفين ان الحركه بتاعتنا فيري جنتل. شايف لفه بسيطه جدا، وبعدين هنبتدي نلف ونبوش. طيب هنبتدي عادي جدا نغير دايركشن بالراحه خالص ونبتدي نبوش.
احمد سامعني؟
طيب هنا ابتدى يعمل. بص خلي بالك برضو التو انجلز هنا، انت ممكن تبقى متخيل ان انت ماشي في الترو اليومن، بس الحته الثانيه لا.
سامعك يا كريم.
فبص على التو انجلز عشان دي تو.
سامعنا كويس؟
طيب هنا ابتدى يروح عند الفيسل من الناحيه الثانيه، لا هنبتدي نغير ونزق.
سامعنا ولا
بالراحه خالص، وبعدين نغير الدايركشن بتاعنا. اوكي، نبوش ثم لفه صغيره.
سامعنا يا كريم؟
ثم بوشنج، بوش اند تيرن، اللي هي ديفليكشن تكنيك، عشان الواير ده مختلف شويه عن الباقي. طبعا انا دخلت هنا في بند، هبتدي ابوش والف لفه صغيره، وبعدين ابوش والف لفه صغيره، ثم ابوش والف لفه صغيره. بلاش الحاجات العنيفه عشان. طيب هو
سامعك
ابتدى
سامعني كويس؟
انا فوق، لا هغير دايركشن شويه وابتدي ابوش الواير. ماشي،
سامعني يا كريم ولا؟
برضو محتاجين لفه صغيره. هنبتدي نبعد عن السب انتيمال سبيس، نغير نرجع لورا تاني ونبتدي نبوش.
تيست.
كل دي المفروض انها CTO سيجمنت.
عشان كده مفيش صوت رايح له. ايوه يا كريم. انت سامعني ولا ما كنتش سامعني؟ الو
استاذ احمد سامعني؟
وانا بس عشان البروجيكتور
انا سامعك. انت سامعني كده ولا ما سامعني؟ ايه؟
طيب بالظبط احنا عدينا الحته دي كلها بقى. عايزين نبتدي ادفانس المايكرو كاتيتر. ازاي هادفانس المايكرو كاتيتر عشان
سامعك. انا كده سامعك. انت سامعني ولا مش سامعني؟
بالظبط. انا هنا مركز على حركه الجايه واير.
ايوه
سامعك. دي اللي هماني
بالظبط.
دلوقتي قوي، يعني كل ما
انت سامعني
بالواير. طيب المايكرو كاتيتر دي مش بوشابل، يعني ما ينفعش اقعد ازقها كده، لا. المايكرو كاتيتر دي هروح ماسك بالصباعين دول. بص انا ماسك بالصباعين دول التوركر بتاعي كويس، والحته دي انا ماسك بيها الجزء ده، وابتدي اعمل روتيشنز. اوكي، هتبتدي تبان.
فاهم؟ انا مش عارف
لازم
اسمع
اثبت
منك
الواير.
الصوت ده ولا-
انا عامل
مش واصل له
روتيشن،
صوت.
كل ما
تيست
المايكرو
تيست
روتيتر
تيست
هتبتدي
تيست.
تعدي. ايوه كاونتر كلوك وايز روتيشن.
ماشي
5 كده ونبتدي نتنشن على الواير بتاعنا. بس بص طبعا هنا عشان بس
تيست
شويه
تيست
الكنترول
تيست
بتاعنا مش اللي هو
تيست
الفيفرابل يعني. المهم
تيست
خلينا
تيست
بس في
تيست
الجاي واير
تيست.
ده الاهم دلوقتي، ان احنا هنبتدي نعمل بوشنج
يعني في صوت جاي لك كده؟
شويه روتيشن بسيط
كده جاي له صوت بس واطي جدا.
لا كده راح فين؟ راح في السايد.
تيست 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 تيست.
ارجع تاني
بسم الله. 1 2 3 4 تيست. 1 2 3 4 تيست. تيست. 1 2 3 4
لا مش الحركه
تيست.
بتاعتنا
1 2 3 4 تيست.
طيب نبتدي نغير شويه الدايركشن.
مين اللي قفل عليا كده؟
لفه صغيره ونعدي من حته ثانيه او بنتريت من حته ثانيه خالص.
تيست. 1 2 3 4 تيست. كريم ولا لا؟ كريم. تيست. 1 2 3 4 تيست. تيست. 1 2 3 4 تيست مايك. تيست مايك. 1 2 3 4.
لا ما دي مهمه عشان تعرف الكنترول بتاعه.
سامعني كده كويس؟
لما هنبتدي نعمل اسمه ايه ده الكنترول بتاعنا، برضو اهم حاجه ان انت بالراحه بوشنج وترن خفيف.
لسه تيست تيست. 1 2 3 4 تيست مايك. انتوا سامعيني يا كريم عندكم ولا لا؟
مش شايف تحت اذا كنت ماشي مظبوط ولا لا.
ها؟
طيب بوشنج وترن خفيف. انا محتاجه تظبط بس يعني ايه، انا طبعا مركز على فوق بوشنج وترن خفيف. المايكرو بس مشكلتها بالنسبه لي هنا بتاع
تيست. 1 2 3 4 تيست مايك. تيست 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 تيست. 1 2 3 4 تيست مايك. تيست مايك.
هو مش باين هنا قوي.
تيست تيست تيست. سامعني يا كريم؟ تيست تيست تيست.
طب كده يبان احسن. طيب هنا هبتدي يطلع في السايد هنا تاني، نرجع تاني ونبوش
الصوت لما يعمل التست بتاعه. الصوت بس الصوت ما تقلقش الزوم، ما تقلقش اللايف
في الدايركشن بالراحه بوش اند تيرن.
الصوت طالع لايف.
So this is a case of CTO right coronary artery.
خلاص كده نفتح كله.
Yes.
Maybe you can find some way. Can you go into cranial? So this is the, we are still looking at the other, we have the extra backup, we find that LED, we use standard LED. We are trying to see if there are collaterals going from left to right. You know, these are the worst collaterals. So the best collaterals are the ones that goes from right to left. And indeed, don't seem that they are so good collaterals. Maybe, but no.
I think this is it. Yeah.
The approach is basically the idea is to go anti-grade.
So this is bilateral femoral or one femoral, one radial?
No, we have bilateral femoral.
Bilateral femoral.
Yes, we have the
6 French or 7 French?
7 French.
7 French, okay.
Left one on the right, after left one on the right artery, which has a very good backup, and is the best choice for a case like that.
Okay, you have two 7 French.
Now the idea is basically to try to see if we can go anti-gravity. So what we try to go is to choose whether to go with stiff wire or copper wire. But because we have a branch, I would prefer to go with stiff wire.
So you have a blunt occlusion?
Blunt occlusion and the side branch.
Side branch, yes. But it's a relatively short occlusion, not a long occlusion. Yes.
So, you hear me well, right?
Yes.
You can hear me well.
Yes.
So we have now first aid.
Yes. 150.
Gaia second. Now the idea is there may be case for anti-gravity section re-entry.
Good.
In case we are going to be. So the first approach would be basically to go to the Gaia, try to find a way. If we go in the section, we might try to go the anti-gravity section or further technique.
Okay.
Retrograde option is probably left as stable option.
معلش عايز اشوف بس سامعني ولا لا. اوكي عايز اشوف سامعني ولا لا. So Dr. Galas, you can hear me or not? Yes. Okay, so your approach will be the anti-grade.
Yes, so the idea is to go anti-grade. And it is possible either in the anti-grade wire mode or in anti-grade section range mode.
Good.
If we cannot do that, we will go for retrograde approach. So now, the selection of the wire for me
Yes.
is mainly stiff wire Gaia, because we have that branch.
Good.
We don't see any channel, so I would suspect that we are not going to do a lot of the clock with any wire. And we also may cause some small flap, and then we will
عشان فيري كلوز للتوتال اوكلوجن طبعا، يعني عشان احنا اداره كورونا برضو وما عندكش حاجه، يعني كده كده هيروح على التوتال اوكلوجن.
الجالسي بيعملوا ده اسمه شورت كات فور وايرز، بس الشورت كات الحقيقه لازم مع وان اكسبيرينسد اوبريتور ان هو بدا ذا فيرست ستيب ويز جايا. اوكي you have to have the experience عشان to start with the Gaia second.
Can we see that? Sorry for this.
Yeah, we see. Yeah. Can the camera concentrate in your hand? We want to show them how the move. We want to see your hand, please.
bend within the occlusion. The wire is bending within the occlusion.
I'm advancing the microcapillary, but the wire is having a sort of S shape, which is usually the case when it's weak. So I'm trying to go very, very close to the vessel. Trying to see if I can find the
Galaxy, can you ask them to concentrate in your hand? Yes, please. Yeah.
اوكي يخشوا معانا في ال
Now the issue is that we have to try to be at least along the vessel. So the good option now is to go area to see, because we have this collateral flow from the same output, we can use this collateral flow to judge the direction of the wire. More. Okay. And this projection, we can make a picture, more picture just to show the direction. Direction not so bad. So now this direction will go more. Trying to see if I can reach. You see, the problem of the garden is small at the distal cap, and it's large at the proximal cap. So this is very unfavorable for getting the symmetry. So the best is to try to navigate in this projection, because we can have a better understanding how far we are from the other. Okay, now once we reach this, we go left. We try to see if we are lucky. We are getting the right direction. And as you can see, it is of course outside of the drum, of the vessel. So this is the problem. So we have to try to make very small movements to see if we can.
So now we are in the subintimal space after the distal cap. Maybe. Yes.
Yeah.
So what are the solution at this point? So you are trying to re-enter by the wire. And I
Now
think
you are fine now.
I'm trying to move the wire in the direction. Okay, now go on and go. You see, I'm doing very little.
بياخد لازم نشوف الدبل بروجيكشنز، يعني ما ينفعش وان بروجيكشن، لازم نغير بروجيكشن نشوف again outside the vessel. Gaia. Yes, Dr. Amr Mansour is suggesting that you can try a parallel wire. Good.
So in this case, we need this wire into the section. Okay.
So again, we are outside the vessel. So I think parallel wire is a good option now, instead of injection a lot from this guide.
But to go in the parallel mode, I need to be a little bit inside the section. So then I need this wire there.
Good.
So I go again, and then
مفروض.
okay, and then I go with the other wire. Okay?
Good.
So take a 2.5 balloon. we do the tracking. So we do tracking now, and we take away the for sale. And of course, I will use the tracking.
So you are asking, Dr. Mu'taz is asking about the frame rate. You are working on the 15 frame rate, yes?
We can work on 7.5.
We prefer this.
And also, I think in this case, it will be a good case for amplification extraction.
You like this? You like this technique?
You
yes?
like this technique?
Well, it can be done. We can try. I have the balloon now to do the right balloon, and we can try that. But before doing this, I will try to be a little more closer to the inner part of the vessel. So first of all, I will try to remove the
Micro.
micro.
So you will go for a parallel wire technique. Next step. Good. ممكن كده وممكن كده. You can do this you can do this. هي هتفاسيليتيت بحيث ان انت ما تخرجش الواير ده وتقدر تستخدمها برضه اريح يعني.
Okay, so we are inflating and keeping the wire.
كله عارف الخطوه دي؟ كله عارف الخطوه دي؟
Now I remove the
المايكرو كاستر هو عايز يخرجها وعايز يخلي الواير ثابت مكانه ما يتحركش، فحط بالونه جوه الجايدنج. البالونه دي هتعمل ايه؟ هينفخها، هتعمل ترابنج على الواير، فكده الواير هيفضل في مكانه ثابت، يقدر يطلع المايكرو كاستر. بالظبط.
السايز بتاع البالونه ايه؟ والبريشر ايه؟
لازم
دي 7 فرنش.
7 فرنش.
7 فرنش هناخد بالونه 2.5. بريشر اللي تعمل بيه ترابنج. لا 16. 14 16 مينيمم. اهم حاجه وانت بتدفليت البالونه ان انت تقلو باك بليد تاني من الجايد، عشان اول ما تفضي البالونه في الجايدنج اللي هي الترابر دي بتعمل نيجاتيف سكشن. لو حقنت بعديها هتحقق نير على طول. احنا دلوقتي هنسحب المايكرو كاثيتر والواير جوه، فمحتاجين ان احنا المايكرو كاثيتر دي واصله لغايه، هنسحب المايكرو كاثيتر ورا سنه لغايه ما تبقى جوه الجايد.
انا عايز اثبت الواير في مكانه بحيث ما يتحركش عشان ما عنديش برفيوجن.
ادي المايكرو كاثيتر رجعناه جوه الجايد خلاص.
what is
نكمل كده جوه الفيسل.
what is the next wire؟
عايز اخرج المايكرو من غير ما اسحب الواير. واخد بالونه جنبها من غير
ده
واير ولا
second؟
حاجه. جنب المايكرو كاثيتر وانفخها هنا. يبقى انا زنقت الواير.
هو احنا ما ينفعش نعمل الحركه بتاعت
ممكن بس مع الواير الجاي ده سفيري ديفيكولت.
عشان البنتري.
We can try for this integrated two-again wire button.
And for
then if not, we go retrograde. So we have different options. And also try, for example, balloon.
Muhammad Imam, do you have ACT in the CAS lab or you send? Okay, they have ACT.
The patient has received 10,000 errors.
It's okay. Back to fenestration technique, anti-grade fenestration technique. Do you prefer to start with small balloon or large balloons?
You mean
in anti-grade fenestration technique? No, in the technique itself.
No. I will do with microcatheter.
Okay.
If it's possible. Yes, I will not. No, I will do. This is a very nice case for.
Which wire?
Because you see, if you would have.
Guy second.
Access, easy retrograde.
Another guy second. Yes.
So you used again a guy second wire?
Yes, another second guy.
Why not a more penetrative wire? Why not a Confianza Pro or Pro 12?
No, because I think the issue is not very
Why not Gaia third to change the wire characteristics?
I usually take a stiffer wire if I see that the first wire is too weak. But this question, I think.
Okay, so wire is suitable for the lesion, and you are using another one for better control and better navigation. Just only you will use the first wire as a guide.
You see that the wire now seems to be two different lanes.
Yes.
Yeah.
But of course we don't know. Now we try to see a picture again.
There is a very good sign هنا في الواير الاولاني يا جماعه ان الواير مش بيتحرك مع حركه الهارت. لو انتوا واخدين بالكم ده a sign for ان الواير الاول sub intimate مش بيتحرك مع نفس الكونتراكشن بتاع الهارت.
First wire looks better in this projection, yes. No, the second is better. Yeah.
شفتوا الالجوريزم لما يبقى في دماغك الجوريزم you will not stuck in the failure mood. يعني ده escalation wire هو عشان عنده الاكسبيرينس enough انه عارف انه محتاج ان الواير ده sub intimal ان هو he shifted to another technique زي الباري واير technique and he will try for 5 or 10 minutes and his mind هيروح عامل كمان another technique وهكذا. فده مهم جدا في السي تي او ان انا ما اقعدش احاول في one technique for long time a lot of dye radiation time. فلازم يبقى في الجوريزم في دماغك وانت دايما شغال سي تي او. I think this wire is better.
Why not to try with a Conquest Pro 12 or like this? It might take another plane.
The problem is right now. The problem is that the battery is small cluster.
I think now we are better. Yeah, you are in. I think.
Multiple projections. Let's see. Yes.
Okay, this is not so bad.
Yes.
We are lucky with it. But unfortunately, I think that we are not lucky. No, we are.
Yes.
The second wire, I think is this one. Let's see now this projection.
هنا احنا بس في ساين مهمه جدا ناخد بالنا منها ان المانيبيوليشنز الاجريسيف اللي كانت في الواير عملت هيماتوما and this hematoma compressed the distal target and now you can recognize the hematoma very well. So this is what you can see now is the hematoma in the subintimal space. This is the staining of this vessel. Okay.
And this is because anti-grade injection يا طارق. Okay.
Yes.
But you know, the fact that we are in hematoma is not so bad because it means that we are. I think we got it.
Yes.
Okay. This is.
We open up the dissection plane and probably now we are in the improvement. Let's see now on the area again. Alors, first go epicrania, please. Okay, first epicrania. Okay, epicrania in this project is very good because we are at the side of the curve, so it gives us the idea if the wire is in the right direction.
We can see the angio.
Yes, it seems to be that we are in the right projection, the right direction now.
We need the RAO again, please.
We need now a
Can we take retrograde injection?
Yes, you are right. Now we will do retrograde injection because now is the time that we need to know the curve.
Yes.
Let's have a look for retrograde and how far we are, because you see the problem of the I think we're not.
Yes.
I think we are not in the
Another projection.
Very difficult to understand.
You can take lateral projection. Or
can we
no?
take another projection, Galaxy?
I think it's time to depend on retrograde injections.
What about the feeling of the wire, the tactile feedback? Is it you feel that the wire is free or still within the tissues?
I think now it's time to go retrograde injection. But let me advance.
I think it's subintimate. We cannot see the.
It is in the section, but very, very close to the actual vesical wall. You see, the problem with Gaia is that sometimes you don't recognize if we are true or not. Go check. Because from this projection seems that the wire is very good. Okay, let's position better the left system. But you know, this is very interesting because Gaia sometimes gives you the impression that you are in the room and you are not. So you have to be very, very careful to make sure, especially with Gaia 30, this is Gaia 2nd, that your position is, that your wire is moving through. I had a case recently, which is indeed with Gaia 3rd, I thought that would be outside. And in fact, well, I was outside, but I had a very good retrograde approach. In this situation, no retrograde approach.
What about the retrograde, Galaxy? You hear me?
والله
There is a problem, there is some disturbance between the two guys. So, of course, I have changed the left, the right. You see, there is some disturbances between the two guys, so interference is a big mess. Okay, let's go back again to Leon.
I'm asking about the left guiding. You don't prefer to put a wire in the left main?
For support.
With this 7 French, no problem, okay? You're working with a 7 French guide, better to put wire in the contra left. If you have any complications, you can treat immediately.
I think it seems to be that we are in protection. So at this stage, most of the issues will depend on the wire and the field. But again, Gaia sometimes gives you the idea that you are going to But now I put it in the room. Thank you. Because it's going, you know, I'm just giving very little pressure because I don't want to make any.
I think you are there. Okay, you are in the true lumen.
Yeah, I think so, because you see, I'm pushing the wire very gently.
Okay.
This is the trick. Never push the wire strong, because Gaia can go everywhere. So what I will do now, I will advance my Corsair. I will try to switch this Gaia with a soft wire.
Okay.
And another good option now is in the small region 2.5 kilowatt.
عشان يتأكد دلوقتي ان هو in the true lumen he will bring a small syringe and will suck from the micro catheter. لو عندنا فري فلو يعني في بلاد جاي بفري فلو، لان انت خلي بالك ممكن لو سب انترنال سبيس كبير وفيه هيماتوما ممكن يجي لك بلاد، بس خلي بالك ان هو فري بيتحرك معاك بيرجع معاك على طول ما انت بتسحب.
طارق هو سامعني؟
الفرق ما بين الترو ليومن والسب انترنال سبيس ان انت السب انترنال سبيس مع النيجاتيف سكشن بيجيب في الاول بلاد بس بيقف بعد كده، انما لو انت في اليومن هيجيب معاك فلو على طول.
الكاميرا ثابته دلوقتي على صوره الانجو.
محتاجين بس الكاميرا على ايد الدكتور جلسي بعد اذنكم. ايوه كويسه. هو بيحتاج بلور لوك، خلاص لور لوك عشان تبقى يعني الحقيقه كومبتنت انف انها وما يحصلش ما يبقاش فيه يعني اي اسكيب من السيرنج نفسها او من يس you will do negative. Yes.
بقول لحضراتكم ايه لو سمحت، الصوت على الفيسبوك، الصوت على الفيسبوك فيه ايكو، الناس مش سامعه الصوت واضح.
Yes, we can see. Yes.
طارق did you hear me؟ طارق سمعني؟
So it's a case of parallel wire technique. Yes. Why spring wire? polymer jacket wire ممكن يعمل perforation. يس حاجتين هيتست ان هو في الترو ليومن لو الواير سبرينج لو بوليمر جاكيت واير كان جو ثرو ذا سب انتيمال سبيس ايزلي اند كان بيرفوريت اولسو. سبرينج واير زي ما اتفقنا اللي هي الوايرات الفضي البي ام دبليو السايون بلو. This wire will not move if you are in the subintimal space. It will buckle. Okay. فك الترابيزه، بيقول لهم فك الترابيزه. اوكي. اول ما يقرب من التيب هيزق بالراحه خالص اهو، مفيش مشكله خلاص. You can take a cranial angulation. Yes, you are sure in the true lumen. Yes. Yes.
Okay, now I can press the wire without any problem. I remove make it 20, 20.
عندي اهو شغال.
مفيش داعي مش مهم. لا ممكن يفضل خلاص.
I have microcarpet, but I have the fixed balloon, so I prefer to use trapping again. I don't want to lose the position because if I lose the position now, it will be not so nice for me. So I have to have already the trapping balloon that I used.
Okay.
So I don't need to install another trapping, another balloon, but because I use the parallel by technique.
All right.
I became my catheter outside the first microcatheter in the guiding, as you can see.
So you removed the first wire and you took the trapping balloon?
I fixed the balloon, the wire.
صوت وحش
Good.
قوي. الايكو ليه الايكو؟
Again. And it is the safest method to remove the microcatheter. So trapping is the safest way.
سامعني كده طارق؟
Yes. You have a great assistant and great team.
Yes, but also get a very stable catheter into the right area.
Yes.
So the parallel way technique was done with a stable guiding in the right area. So I could move very minimally the wire in and out, making the curve without altering the position of the
خلاص مش مشكلة.
guiding stable, you can place the parallel way technique in the proper way.
Good.
If the guiding is not stable, and every
اه
time you
عشان
push in and out of the layer,
ايوه اهو
the guiding is
عادي
going back.
موجود.
Then you will be not having a good recanalization.
So Jopkins is not suitable for such approach.
Back and forth. You will create all of these sections, and then once you create this section, you will never re-enter anymore. So the secret of parallel wire technique is to have a very stable guiding. I learned this when I was using Conquest and Confianza, which were very stiff. And I tell you that this learning was very good for me because every time now that I plan for integrated approach, parallel wire technique or whatever, I always try to have very stable guiding. Okay.
Good.
So now we go with the balloon.
This is a very good point that if you are going to do the parallel wire technique, you have to take a very stable guiding because the movement of the guiding in and out, if you took like a Jopkins right, and you are pushing the wire, the guiding is going out. This will increase the manipulation of the second wire in the subintimal space and will increase the hematoma and will compress the true lumen. So stable guiding is the key point in this case.
So it was a very basic procedure, but I think for people who are, at the first
So we lost
approach of CTO. I think it was very interesting because you were understanding that.
Okay. Now we can hear you. Yes. Okay.
Can you hear me?
Yes. Yes. Okay.
It's very important this procedure because those is a simple.
ما شغال عادي، انا ما عنديش مشكله. الصوت راح دلوقتي بتاع الراجل، الصوت راح من عندكم.
The life is not good.
كده رجع.
Can you hear me now?
Now it's okay. Now it's okay. Okay.
Okay. So basically, what is I want to show in this case is a basic, simple, standard case. But as you understood, I think it's good for presentation because you understand that even a standard parallel wire technique should be treated with very kind attention because otherwise you can go off of the main vessel very easily, create the section, not re-enter anymore. And the most important issue of parallel wire technique is to take always two orthogonal planes to check the artery and to see where is the first wire, where is the second wire. Never going too much deep because if you create the section plane, then you will never re-enter. And so with the good assistance of the technician, the good assistance of Mohammed and the nurse, we were able to do, even with we were lucky to do this.
Of course, you are lucky today because I'm not with you.
No, but because it's a simple case. But simple case, you know, sometimes are more instructive than can you do 20? Where? Yeah, I close everything.
Yeah.
I cannot see because I cannot see. Go to 20. 20. Okay, so okay, we can open up here. I think we are at the origin, but because it's going very smoothly, so we can do even from the proximal to the distal. Okay.
ACT. So we didn't ask you about this important issue.
This is a very important issue. I always recommend all CAT labs that do CTO to always gently. Yeah? So now the trick is this. We will inject the artery, but very gently, because we know that we have a dissection. So if we inject very strong, the vessel will dissect all the way through. So very gentle, just to understand, little bit to understand. Okay, like this, perfect. You see?
We can
fantastic.
see.
You see?
Please, we need
now, this is the most important issue because we know that we are in.
It's okay.
We were in some hematoma there. Now we don't see the hematoma anymore. The result is very good. We are in the true lumen. So now what we do? We do a little bit more dilatation in the proximal. Then we take a 3O balloon for the proximal. Do you agree?
But I think the entry is distal to the distal cab. And there is a dissection in false lumen, then we do the entry distal.
You need another
in the true lumen?
case.
The wire is in the true lumen.
You know, you never know.
That's enough.
This projection, the other projection will be different. Inflated balloon. This, hi. We need a 3O balloon because the vessel is very large there. Okay. Okay, go. Now we take another picture. Go area. Okay. Very gently again. Another good. Now or 3.5? Even 3.5.
Give me 3.5.
Any suggestion from the panel?
3.5
Okay. 3.5, no? Would you agree? Mohammed is suggesting 3.5. Can you hear us?
انا بقالي ساعتين يا دينا على البتاع. طارق سامعني؟
for re-entry from the, there is no flip of dissection here. You have only small lumen up and you don't have a flip.
I think that the
we'll take
re-entry
more
is around
projection
here.
to see the disease segment, and then we will decide for stenting, yes, as usual. You are now dealing with a case of
because the balloon inflated length.
a lesion,
Now
not,
if
not
you
a
deflate,
CTO. So we will decide for stenting for...
you see, now it's deflating.
Dr. Galassi, can you use IVUS for sizing of the vessel and for assessing the extent of the disease and to see
I
what's
can do
going on?
whatever you want.
We prefer to use IVUS. IVUS, okay?
Okay, go Leo. We can do whatever you want.
I think IVUS will be a very good option.
Just we need to IVUS these vessels to see what's going on, to see where is the point of entry into the true lumen, and if we did any dissection re-entry or only you are true from the beginning. Of course,
but it's clear that this section is all dissected up to the marginal branch. Then there's a re-entry. You see?
Yes. So we can see by IVUS. Intravascular imaging is good in such situation.
Okay. So, but we knew where it is because following the procedure, as Tarek was saying, we saw some hematoma in the curve, and after the curve of the hematoma, I had the sensation of re-entry, and that was the place of re-entry. But we will confirm by IVUS.
Okay.
Of course.
So IVUS is a good idea to assess the vessel size, to assess the point of re-entry, to see.
The problem is that IVUS is not here.
Yes.
With us.
IVUS is ready.
So if you agree, I remove the left system because we don't need the left system anymore.
اخترت الايفس فين؟ حد يفتح الايفس.
Huh? And theoretically, I could switch the.
Dr. Amr, you have a question? Dr. Amr Al-Hadidi, you have a question, Dr. Galassi?
It's a very nice case. Do you hear me?
Yes.
It's a very nice case, Galaxy, as usual. It's very good how to demonstrate how to use the wires, the microcaster, how to go from the, sometimes I think is a part is false lumen, a subintimal, and I think you can enter again. And I think the very good, very important point that you show us from the retrograde, where the wire, the distal wire, is very important to have more than one projection. And I think this is a very good demonstration how to cross with the anti-grid approach when you have a good collaterals from retrograde. Do you think?
But we were lucky also. We had a very good team and we were very lucky.
Yes, you are lucky because you have Muhammad Imam.
You always need three things.
If I am with you, you'll not be lucky.
To be lucky and then some expertise. Three things. Okay, Iris.
Where's Iris?
Will come. Will come. Will come, Iris.
Welcome, Iris, or welcome.
Galaxy, I would like to ask you a very short question.
Yes, while we are not doing anything, we will be glad to answer to you.
Okay. What about if you have if you decide there is a big subintimal hematoma? Is it good for you to withdraw blood from this subintimal space with the big syringe? What do you think? What is the tips and tricks to reduce the size of hematoma?
So if I understood correctly, I mean, there's a secret when you are in a situation like this of parallel technique is to limit your subintimal dissection. So if the two wires are trying to go into the true lumen, of course, more and more you go on the side of the vessel, outside the inner part of the vessel, more you create dissection, hematoma, and then more you have the chance not to get the true lumen. So the secret is to have a very stable guiding. Moving the wires as we did very, very little into that direction without making too much movements. And also what is good, and I forgot to tell you that the second wire, the second Gaia, I made additional bend. Usually when I do parallel technique, I always do like this because the second wire can find sort of swap and re-entry into the false lumen again in the true lumen. Usually I do like this. So I add a very small bend to the second Gaia. And the secret is to move as little as possible. If you create a hematoma, let's say that we are not lucky and we create a hematoma, then the only thing to do is to go more distally or more proximally to try to see if you can re-enter in a different side of the segment of the vessel.
Yeah.
But usually I prefer first to try to go more back, and then if not, to go more distally. More back because I can find a different plane from the beginning. More distally because I assume that the distal vessel is smaller than the proximal and I have more chance to re-enter. But of course, these are the two alternatives. Having overcome these two possibilities and not having been successful, then I would have gone with the probably dual guide wire balloon, and I would have tried to re-enter by the second wire. If failure, then I would have gone to retrograde approach. But in this case, retrograde approach was not so nice, so I would have preferred to go more retrograde approach rather than to go retrograde approach.
Okay.
I hope it was clear. My
yes, very clear.
Very clear. I do now the IRUS.
So my question, Professor Galassi, is
IRUS. Where is IRUS? IRUS is in my back.
Okay.
So so I have to up. Okay. Now we are with the IRUS into the distal part of the artery here.
We need to see IVUS, please.
Okay.
The IVUS image.
Me too.
Yes.
You are not the only one who want to see. Okay. So here is the IVUS. كده شايفين الIVUS؟ Ring down.
لا مش شايفين كويس.
Ring down.
ممكن تقربوا شويه، قربوا شويه ناحيه جلسي.
ايوه ماشي.
ايوه.
Ring down.
زقوا ناحيه جلسي. لان احنا شايفين ما بينكم كده. اوعى دماغك يا امام.
حاضر يا دكتور عمرو. Here, ring down.
منور يا امام منور.
So now we are in the proximal. The artery is very calcified. Seems to be very calcified. I'll go a little bit more inside.
For me, it's not a heavy calcification. It may be a fibrotic lesion because if a heavy calcification, you will not see the back of the vessel. This white ring is not a calcification.
You can see the false lumen, which is between 6 and 9. You can see the false lumen between 6 and 9. I'm going a little bit more inside. This is the more clear now. The between 9
محمد الماسك هنا محمد سن عشان نشوف بس.
الماسك يا محمد بيتحرك يمين وشمال.
And then here you see after where basically we thought that this is true lumen again.
Yes, this is the true lumen.
This was. Can you see the angel?
Yeah.
No, the angel.
See the
yes, this is okay. This is okay.
Okay, this is the place where we knew that he was re-entering. We discussed with Mohammed and we know where we re-entered. So confirmation came by IRUS, but our eyes were more or less the same of IRUS.
I was expecting that the entry is distal to that level, but
so that is the place of re-entry. And you can see now there's a true lumen. If I go back, you will see the flap of the section. Here's the flap of the section between 6 and 9. The vessel is like the moon shape of the.
Don't zoom, please. Again, zoom out.
Okay. So
this is okay. Don't do more. Image is excellent. So this white ring is not.
Theoretically, you should not stent this segment theoretically because it seems to be nice.
Excellent. How can you differentiate this white ring between calcification and fibrosis?
So theoretically, we should stent from here to there. So theoretically, we should stent from the ostium to there.
بالظبط. calcification هتشوف اسود مش هتشوف الفيسل، انما الفايبروتيك ليجن the vessel structure good. هتشوف كل حاجه.
Okay, so from there to there we reconstruct. Okay. So we start with 3.5. Huh?
What? 3.5.
The size of the stent is here is.
I think 3.5 will be very good.
Is 3. Yeah. So 3.5 is okay.
3.5.
Do you agree with 3.5?
3.5.
3.5 is okay.
IRUS is telling us 2, 3, 3, 3, 3.5. Yes, almost 3.5. So we can't do more than 3.5. So we take 3.5.
That's good.
And we take a long stent. Now, the most difficult part of this procedure is try not to disengage the artery, because this guiding was very good for the procedure, but maybe a little bit bad for now for the positioning of the stent. So we have to be very careful, because he went into the artery very deep, so we want to get it a little bit back, but not too much. So we put the stent first.
But go is
3.5 the length of the stent, I think by the IVUS can be measured, but okay, we don't measure, we did not measure, it's about 38. We will see. What do you think, 38? You want to measure by the balloon? I think
3.5, 38.
Yeah. It was about probably with 138, 38 we will be okay. Otherwise, it is 3.36, 35, 36. Okay, let's try with this first. And then in case we put another additional stent 4.0, because the region is very, very large. So you remember there was a big discrepancy. Now the guiding is in the big, large artery, which is a bit like 4. So if we cannot cover properly the whole lesion, then we will go with 4.0. But I think that probably we might be able.
So this is the distal stent.
You will use the big one stent, I think.
I think with one stent we might be able.
One stent will be good.
Yes,
I don't think so.
I think so.
You will
because
need more distal. I think you have to cover this bend.
Straight away, because this is the most difficult part. Okay, test. You see, this is now the problem. The guiding is in and out. Is going like a spring, in and out. So we have to be very careful. 1 minute, Mohammed, because otherwise we make a mess. Okay, test now. Okay.
I think this place is good, but the stent is...
If we want, we can put a stent a little bit more distally, like this, and then we put 4, huh?
Yeah. It is 331.
Okay, so implant like this.
And it's 4 after.
Okay, implant like
I
this.
prefer to cover this lesion. And more distal, I think.
Okay, go. And then, okay, say yes, we were doing very nice. And then we take a 4.0 short.
Okay.
For the proximal artery.
Shall we have a picture in this situation?
Yes. Okay. Okay. Very good.
Very nice.
For the proximal artery will be.
I think 3.5 also.
3.5. Okay, 3.5.
I think 4 will be.
In the IVUS, it's about 3.5.
I was actually was saying to is about 3.5, 3.7. Anyway, it's okay. We can play with 3.5. We can always expand 3.5.
لا جيب 3.5 قصير.
But we want to check the IVUS again after, no? If you want.
Okay, after putting the stent.
Okay. Why not?
ننزل IVUS. 3.5 by 18 and 14.
Oh, 14 is enough. No? 14 is enough.
Okay. I think 18 will be
14 or 18. What do you think? The second stent.
Can we see the the last picture?
18 will be very good, but 18 will. I think 14 is enough. 14 is enough. We go from there to there.
Okay.
Because already we go into the ostium of left main.
Okay.
14.
14.
For me, 14.
Okay.
But okay, 14. How was dinner at the hotel? Was good?
Yes, he's asking about the dinner.
We missed it.
I think while he was in the hospital, he was asking for the dinner.
Actually, I'm not eating since last night.
Dr. Muhammad Imam will take you to the best restaurant in Bursaid and you will eat the best food. Don't worry.
You want seafood or?
Yes, please, Muhammad, please. All of us want seafood.
So let me put first assistant because
الون يا طارق لوحدك.
ما انت مش عايز تيجي بقى دكتور عمرو نعمل ايه؟
Okay, I think it's a good position.
Yes.
Shall I come up?
Okay. Would you agree? Yes. Go. Go.
4,
please.
6.
Okay.
14.
14, 16.
higher.
Okay, okay.
18.
ثانك يو يا دكتور عمرو بجد ان انت لسه معانا لغايه اللحظه دي يعني.
يعني really
دكتور عمرو.
لا ياسر ازيك اخبارك
بشكرك
ايه؟
جدا والله ان انت
We
معانا
appreciating
لغايه
this.
دلوقتي.
Really appreciating.
Okay, go now here again. Now you can go to 18. We do overlap.
18.
Very good. Deflate.
We need Iris after this, please.
Yes.
Yes.
Okay, we need Iris.
Yeah, great.
Oh, perfect. We can probably overexpand a little bit the first tent with the
Yes.
35, 375, and that's it. Huh?
Yeah. Yes.
Yeah, but on the other hand, I think it's.
Do you think, Galaxy, that the mid part of the stent is more bigger because of some part is sub-intimal space? What do you think, Galaxy? This.
Yes, probably. Yes, because up to the branch, the suboccluded branch is clearly in the section. Then after we have the suboccluded branch, which is around 9 o'clock, then it's coming to be the true lumen. You can see that the rest is
This was this was very obvious when you are putting the stent in the mid part of the RCA, that you see that the distal part is small and the proximal part is big, because this is, as you mentioned, this is the site of the false lumen. Yeah.
Galaxy.
3.5
Galaxy.
Yes.
Seems that there is a dissection in the BDA down in the artery. So can we check it by IVUS or cranial for the PL? Yeah.
The PL, yeah?
PL.
Oh yeah, in the BL.
Yes.
Okay.
Maybe from the stick wire, maybe.
But you want to do a stent there?
No, we want to do IVUS to see it clear.
Okay, anyway, now first we optimize, first we see the stent, the proximal stent. Then we optimize the proximal, and then we discuss about the distality.
Of course, after optimizing the stent with the NEC balloon, we'll check by IVUS everything. And this
NEC
is
balloon?
بالون 375.
375 if you have, or 35.
NEC.
Now, if the procedure is being to be a little bit longer now, remember that we have to check ACT.
We checked the ACT and is 331.
Perfect. Okay.
Okay.
But see, this was also the secret to put to BMW, because BMW dissected. Imagine if you would have inserted another wire. You would have had the dissection, total dissection. But you remember that at the beginning there was low flow in the PL, eh?
Yeah.
So maybe that. Okay. Allora, here we are. Now we go a little bit out. Okay.
Yeah. You can see the IVUS.
You can see the IVUS. There is a little bit of.
No, we can see. Oh, now yes.
Down. Okay. Now we go inside the stent. Now we are inside the stent. here maybe a little bit underdeployed. Here is underdeployed, in fact, as you can see a little bit.
الماسك محمد والنبي اللي احنا يعني بص.
And then
الرجاله دي تشيلهولك من هنا.
This is the section, as you can see.
Yes.
And now comes the true lumen. You see, very interesting, because if you see, if I go back in the section, you can see now the section part from 10 to 6, the usual moon shape is compressed by the stent, you see? Good. So we need to compress a little bit more, but this would be thrombose, of course. And then after that, you will see that this disappears. You see, this is true lumen. So this is a clear demonstration of the passage from what he was saying, Amr Labidi, from false to true.
Yes.
Okay. So now we optimize the, you want to see the distal vessel? The problem is, I don't want to go with this, I don't want to create with the IVUS problem in the distal part of the vessel. Can you go epicranial? Can you go epicranial? Because usually in the small vessel, if you advance the IVUS, sometimes you create a disaster. Huh?
Sometimes goes through, the IVUS causes trauma to the distal part if it's...
You create a disaster. Yes. So let me do as I do usually.
I think, no need to... Don't do IVUS in this distal part because it may increase the dissection. Maybe small, very small. But
yeah, but anyway, it's a small branch. I don't think that
very small disease.
It's a timid flow without any flow limiting.
Because, okay, 375 12. Because if I put IVUS and then I dissect more, then I'm obliged to put a stent. So first of all,
I think.
I usually do in the clinical setting.
Can we see it in epicranial, Galaxy?
Yes, we will see. First, let me optimize 1 minute the proximal part, and then we do epicranial, and then we'll see what to do. I tell you something, if we would have used Sion, that would not have caused problem in the PL.
Yeah.
Because the philicity of Sion is much different from BMW. But on the other hand, if you take instead of Sion another wire, then you can have a dissection. So there's always some price to pay, and if I have no Sion, I prefer to go on the safe side. But this can be caused by the floppy wire of the actual constitution of the BMW, which create some dissection there. Although it's not relevant, but this is the issue. Okay. So let's do our expansion there of the stand.
You want a post?
No, but you can see it. It's inside.
Yeah. Okay.
So we are expanding there.
8, 10, 12, 14,
companion balloon.
16.
This is 3.75?
Yes. By 12. Okay. Deflate. Okay, now we do a little bit more inside. In the curve, okay, go. Here's still the subintimal segment. Of course, we don't need to do it. We don't need to exaggerate it because, by the way, we'll thrombose. Okay, deflate, and then we will do a little bit more in the distal part. Okay, there, which is the segment between the dissection and the true lumen. This is more important because it's the place where the stent should be really shaped in the proper way. Because there you can have rethrombosis. It's not this the case because the vessel is very big, but sometimes, okay. Now, deflate. Okay, so I think we did all what we needed. Now, now we check in this projection, then we go epicranial. Okay, wait. We check first.
We have, great.
I think
we have
okay.
some nitro. Some nitro.
Let's go epicranial.
I think it's a branch out of that section in the PL.
Yeah.
Now we will check the.
I think Dr. Tari is right. There's another dissection in the distal BL.
Yes, I know. but I will not do anything.
Yes.
For me.
Chemistry flow, no problem. Small vessel disease, no problem.
Okay.
Perfect.
I think it's great.
So if you agree, I would remove the we can stop. Do you
Yes.
agree?
Yes, we agree.
I will go together. Okay, so we remove the wire. We take the nitro, a little bit of nitro, and we do the rest in cranial.
Remove the wire
nitro, please.
Remove the wire.
Eleocranial. A little bit, no, a little bit more AP. Not too much. Like this, AP. Okay, very good, like this, perfect. Okay, well done. Okay, nitro. Now Mohammed will do nitro. Pressure was 120, patient was stable. He's a young patient, no? How old is
48.
So CTO in young patient is always easier. Okay, focus a little bit on the distal also. Focus trapezius a little bit distal.
Focus trapezius.
Okay, well, not more. Okay, like this. Very good. Go.
Yes, it's a dissection.
Okay, there is a flap of dissection.
Yes.
But I don't think that needs to be treated, because if you put a stent there, you have to go up to the branch, and then I think it's really.
It's non-flow limiting, and flow is okay, and everything is good. And you will put a very small stent, and it will close. So I think that's good.
I think this is.
You want to put another stent?
No.
You want to put another stent?
No, it's okay.
Oh.
No, it's okay. No stent. It's a very small vessel.
No.
It will heal with time.
Okay. Even because if we put a stent, we have to go from there till the distal kink, which seems
Thank you. Fantastic result, Galaxy. Great case.
Great case.
Okay, thank you very much. Thanks a lot.
Thank you. It's a very good demonstration
Thank you,
of the
Dr.
parallel
Galaxy.
wire technique. Thank you, Galas. Thank you, Dr. Muhammad Imam. Thank you, everyone there in this excellent class lab. And now we will move for simulation of the wire. Thank you, Dr. Amr Al-Hadidi, for your contribution today, all the day. And now for the wire simulation. Thank you.
Thank you.
احنا طبعا التريكس بس اللي نستفيدها من الموضوع طبعا ستيل parallel wire technique is valid. ما نقولش عليه ده حاجه old واولد از جولد، فهو رجع تاني تكنيك مهم جدا بالنسبه لنا. ممكن تفاسيليتيت التكنيك ده بان انت تستخدم دبل من كاثيتر. الفكره كلها في ان هو ناتشورال واير اسكاليشن، بدل ما تسحب واير وتاخد واير تاني استفيد من الواير اللي انت حطيته ده، اعرف يعني خد منه بعض الديتيلز. الواير ده بيديك
عادي هيروح كمان شويه.
هو الواير ده بيستريتن الفيثل نفسه، بيخلي الفيثل ستريت، فتقدر تخش بالواير الثاني جنبه بسهوله. لاند مارك كويسه بالنسبه لك، ما تعملش اوفر مانيبيوليشن في سب انتيمال سبيس. الواير الثاني هيبقى مور ستيفر، ده الريكومندد. يعني انت لو خدت جاي سكند ممكن تاخد جاي ثيرد، ممكن بدل جاي سكند او ثيرد تاخد كونكس برو 12. هي دي الفكره، يعني دايما بتاخد مور ستيفر واير. فهو ناتشورال اسكاليشن، ما فيش حاجه زياده. يعني الحاجه المهمه اللي قالها دكتور جلسي ان انت لو هتعمل بارallel واير تكنيك يو هاف تو تيك ا ستيبل جايدنج، ما تاخدش جايدنج بتروح وتيجي. لان الجايدنج الموفنج جايدنج هتحرك الواير معاك اللي هو في الاولاني، والواير الثاني هتغير المانيبيوليشن بتاعته، فهنكبر الهيماتوما ويحصل عندنا كومبريشن للديستال ترو اليومن. فدي بعض التيبس والتريكس. شفنا هنا الايفاس فين. دكتور عمرو.
Thank you, Tariq. Good night and see you tomorrow.
Thank you, Dr. Amr. We are appreciating your attendance الحقيقة، ويعني ما كناش متوقعين خالص ان حضرتك هتكمل معانا لغاية الوقت المتأخر ده. بنشكر حضرتك جدا على تعبك ومجهودك معانا النهارده. Thank you, Dr. Amr. and برضه بنحب نشكر الدكتور نبيل اللي قعد معانا لفترة طويلة. هو مش موجود معانا دلوقتي، بس الحقيقة هو حضر جزء كبير من الميتنج. يعني. طيب احنا دلوقتي هنكمل على السيميليشن. التريكس اللي هو قالها ان الجايدنج تبقى ستيبل، برضو خلي بالك ما تحقنش كتير من الجايدنج عشان ده ممكن يوسع السب انتمال سبيس. بس في اي حد يعني اي حد عنده سؤال من اعتقد هو almost 5.8 جراي او 6 جراي دي لارج دوز طبعا عشان نشتغل على 15 فريم. اعتقد الكونتراست كتير برضه عشان 7 فرنش جايد يعني. معلش يعني مع الوقت بتتعود عليها يعني. هي عشان انتي جريد كيس فهو خلاص ما حبش يقلل الفريم ريت، انما لو كانت هتقلب ريترو جريد كان يستحسن ان هو يقلل الفريم ريت. Yes, of course you have deeply engaged catheter ممكن تعمل dissection في الاوستيوم، فلازم نخلي بالنا to check يعني. لا طبعا هو قال ان هنا الريتروجريد اوبشنز از نوت جود لان هو ما كانش عنده جود انترفنشن كولاترال، كان عندنا لاندنج زون مش بطاله يعني كويسه، ونفس الوقت السيجمنت مش طويله، وهو قدر يعدي بواير يعني من واير مش هيفي واير من البروكسيمال كاب بقى في البادي، فبالتالي كمل عادي ما فيش مشكله.